Okay, everybody. Well, I want to talk now about another form of assessment before we move to our first set of disorders, anxiety disorders. I'm just going to introduce them in today's lecture. And then next class this week, we'll get into some of the disorders that are involved in that category. But before we get to that, I want to finish up our assessment discussion talking about intelligence tests, because on the one hand, they are fairly widely used. On the other, they're very controversial. So the most widely intelligence tests, or IQ tests as they're called, that are used are the Wechsler scales and the Stanford-Binet scales. Stanford-Binet is a little bit more complicated to administer than the Wechsler, but these are supposed to measure your so-called IQ, or intelligence quotient. And among things that it measures is reasoning ability. Now, look at the left-hand side of slide number 22. You will see what is called a bell curve. This is a well-known bell curve for IQ distribution scores after thousands and thousands and thousands of people have been tested on these IQ tests. So the idea is if we took everybody's score on an IQ test like the Wechsler scale and we plotted them, we would see them distributed in what is known as a normal bell curve. This means most people's scores would fall somewhere between the center of the bell curve. And so you can see the peak, right, of the scores is right in the middle. The average is 100. And then most people score within 2 standard deviations. Actually, even more people score within 1 standard deviation, between 85 and 115. So that's normal range. Then we have some people scoring between 70 and 130. 2 standard deviations away from the mean, and then we have far fewer people in the tails of the distribution on either side. So far fewer people scoring below 70 or above 130, right? This is what we call a normal curve because most scores fall within the center of the curve and forms kind of a bell shape, with fewer people out in the tails of the distribution. As scores move away from the average, which is 100, we'll find fewer and fewer scores the further away we get from that average. But to make the numbers meaningful, we have to be able to measure the variability of the scores. And we can't just say the average is 100. What's the variability? How much variation around that average do we actually see? That's the purpose of a standard deviation. The standard deviation, very simply, tells you the distance the scores are from the average. Statisticians determine the standard deviation through a formula, which is beyond the scope of this class. So the idea is, once you understand these scores and how they fit into a bell curve, you can kind of understand categories of giftedness and categories of what's known as intellectual developmental disorder, right? So if most people are, if the average is 100 and most people score somewhere between 85 and 115, then we're saying anybody who is at, let's say, between 115 and 130 is mildly gifted. Because far fewer people score at that higher end of the continuum. And then if we see people who are scoring between 130 and 145, very few, less than 3% score there. So we say that's highly gifted. This is based on the so-called Deviance model. Remember the 4 Ds? Deviance was one of them. How do we determine the meaning of abnormality, right? So we talked about the Deviance model, meaning one definition is we take the average score in a population of interest, and then anything that deviates from that, especially the further away it deviates, the more we consider that clinically relevant. So in the case of IQ, it's based on a Deviance model. If most people score between 85 and 115 and the average is 100, then deviations from that on either side are relevant. The further away from the norm or the average in the left-hand direction, 70, 55, the more we become concerned about intellectual disability. The higher the score towards the right end of the continuum, up towards 130, 145, the more we say intellectual giftedness, because it's so far above the average person's score. Now, what to think about with this, though, is there are several functions of IQ testing from a clinical standpoint. One, we use it to estimate a person's current level of cognitive functioning. That's important, especially when it comes to active symptoms of mental illness, and we'll get to that in a minute. We also use IQ scores to estimate a person's level of performance relative to same-aged others. So again, it's used for things like intellectual developmental disorder, which used to be called mental retardation. If somebody at a particular age, let's say 6 years old, is performing well below the average IQ for other 6-year-olds, we compare people to the norm for their own group. Remember, norming is really important in measuring standardized tests. Then we say there might be an intellectual developmental disorder there. And finally, third purpose of IQ testing, estimate the degree of intellectual deterioration caused by active symptoms of mental illness. Psychosis, when people are out of touch with reality. Depression, when people actively show symptoms of depression. Anxiety. This is very important because we can compare people's IQ scores when they are in remission, meaning they're not showing symptoms of their disorder or their symptoms are controlled. We can compare IQ scores in those circumstances with circumstances in which they take the same test but are actively symptomatic. And what we know, anxiety, depression, psychosis, all of these things impact IQ because they impact individuals' cognitive and intellectual functioning. So we can use an IQ test to get a really good indicator of how much disability and dysfunction active symptoms of an illness are causing, because when people are not actively symptomatic, their scores differ. For example, if I test somebody's IQ and I find when that person is not actively symptomatic, her IQ is a 120, which is above average. But when she is experiencing active symptoms of depression, her score drops to 100 or 90. Then I can say the symptoms of her illness are interfering with intellectual and cognitive functioning. And that's a less controversial use of IQ scores than the other two. And the reason it's controversial is there's been criticisms, if we go to slide number 23, there's been criticisms that sociocultural factors influence performance on these tests. So is it really measuring someone's intellectual ability and potential? Or are the types of questions included in standardized IQ tests commonly things that people of particular culture or cultural status would have learned? And it's not that people who perform poorly from other cultures or different cultural statuses are less capable, but that they haven't had exposure to the same thing, so they won't perform as well on the test. That's why there's been some attempts to come up with what are called culture-free tests, like the Raven matrices. It is a test, it's a non-verbal tool that doesn't depend on educational experience of the test taker. Next, IQ is often misunderstood, misinterpreted, overinterpreted, and can lead to all sorts of self-fulfilling prophecies. Oftentimes, the meaning of an IQ score leads people to believe that if they don't perform as well on it as they should, they're not capable of learning, they're not capable of improving. That can make them develop a self-concept that they're not smart, and then a self-fulfilling prophecy happens where they start to act in ways that confirm their belief that they're not intelligent, they give up, they're not motivated. There's also a lot of debate in terms of what IQ scores actually predict. So when we say they predict success, how are we operationally defining success? Operational definition in science means how are we going to measure the construct that is more abstract, right? So happiness, for example, is an abstract concept. But if we want to measure it, we have to figure out a tangible way to do so. So we might say, I'm going to ask people questions about how happy they are, and I'm going to assume their answers to those questions are indicative of their happiness. Same with IQ. The idea of an intelligence quotient or your intellectual potential is somewhat vague. It's not tangible. The idea is these questions on these tests somehow indicate that potential. But do they? Because some studies show that IQ tests do not accurately predict. There's a bug crawling on my wall. I'm sorry, it distracted me for a second. Long legs. I'm not scared of bugs, but wow, that's a big one. A lot of people say that IQ tests do not have what we call predictive validity. Remember what predictive validity is from a prior video. See how these things are important? Predictive validity measures the extent to which a test accurately forecasts someone's future performance in something, whatever it's meant to gauge, right? So if we're trying to predict somebody's future success in college, in school, in a job, then the IQ test should accurately predict how successful they will be in those venues. If the score does not do that, then it doesn't have predictive validity. Last, another big criticism. Let's start over. Take two. Another big criticism of IQ tests is that intelligence is multidimensional, but these IQ tests only test one or assess one dimension of intelligence. And one of the most well-known theories of multidimensional intelligence was by a professor named Gardner at Harvard. His theory of multiple intelligences, you may have learned about it in introductory psych at some point. He talked about different forms of intelligence: emotional intelligence, kinesthetic intelligence, so people who are dancers or athletes that can move their bodies through space in incredible ways. The idea of social intelligence. So the idea is that, you know, these IQ tests have a very narrow definition of what intelligence is. And it's leaving out all of these other adaptable forms of intelligence that can make people successful in the world. So when it comes to clinical assessment, the use of the IQ test can be helpful in determining the extremes. People who have intellectual developmental disorder, used to be called mental retardation, or people who have extreme levels of giftedness, but everything in the middle is a lot more controversial in terms of its predictive validity. So the last thing I want to talk about before we go to our last video of this lecture is observations. So I've been telling you about all these different types of assessment tools, and as I keep saying, the best assessment is multidimensional. The best assessment to arrive at a clinical decision, a clinical diagnosis, a clinical category, treatment, the best assessment is multidimensional. It should have corroborating evidence from different assessment sources. So all these different types of assessments that I've been teaching you about over the last few classes, clinicians should be drawing from different ones of these and seeing what conclusion they collectively point to. No one test should be used to make a clinical decision. So the last one I want to tell you about that happens commonly in clinical practice is observations. Now, before I say anything else, if you look at slide number 24, at the top, there are two links. They're very brief. I want you to watch them before you come back to my video. These show you each a structured, what we call a structured observation, and an unstructured observation. So take a look at those first, and then come back and meet me to discuss this, or to hear me discuss it. Pause here so you can watch the videos, okay? And then come back. Hope you watch the videos. We're back. Clinical observations can be controlled or naturalistic. So there's four things I want you to understand here: the difference between a structured and an unstructured observation, and the difference between a controlled and a naturalistic observation, okay? Very important. Structured versus unstructured refers to the degree to which the clinician doing the observation sets up in advance of the observation what he or she will be looking for. Okay, so kind of similar to structured and unstructured interviews, except applied to an observation. Remember, you learned about structured and unstructured interviews. Same idea applied to an observation. So in an observation, the clinician is going to actually be watching a person or a group of persons that he or she wants to assess in a particular environment. In a structured observation, the individual comes to that observation, that viewing of the individual or individuals, with a preset list of behaviors that the clinician is looking for. So for example, in the video I showed you, the clinician was watching the child interacting with a parent. The clinician had a sheet in front of her, a checklist of behaviors that the parent might be engaging in, and she knew exactly what she was looking for when she was watching the parent-child interaction. An unstructured interview, an unstructured observation, much like an unstructured interview, involves a situation in which the clinician has no predetermined set of behaviors that he or she is going to look for. Just like in an unstructured interview where the clinician doesn't have a predetermined set of questions she's going to ask the client. Here, the clinician goes into the observation without a predetermined set of behaviors to look for, and instead just observes and takes narrative notes. So it doesn't have a checklist like in the structured observation of behaviors to assess, just going to take narrative notes and then go back later and has to figure out how to make meaningful sense or code those observations. So you can see in the second example I gave you, the clinician is just watching the interactions and taking narrative notes. Now, the next concept I want you to understand is that clinical observations can be controlled or naturalistic. These are independent of the structured versus unstructured observation. Now, a structured observation can be controlled, an unstructured observation can be controlled. A structured observation can be naturalistic, an unstructured observation can be naturalistic. So controlled or naturalistic has to do with the setting in which the observations take place. If the setting is controlled, we also call this an analog or laboratory or contrived setting. It means that the clinician is going to observe the individual or individuals in question and their responses to specific stimuli and situations in a setting that is similar to, but is not the actual setting in which these behaviors naturally take place. So for example, clinician might bring a parent and child into her office and have a room that is set up like a playroom. That's why it's called an analog setting. It's analogous to what the natural setting looks like, but it's not the actual setting in which the behavior occurs. A naturalistic observation setting is one in which the individual doing the assessment actually observes the person or persons in question in their home natural environment. It could be the home, it could be the school, it could be the hospital that they're in, it could be their office. The point is, a naturalistic observation takes place in the actual environment in which the behaviors in question ordinarily occur, right? So if they're going to observe a parent-child interaction, they're going to actually go to that person's house. If they're going to observe a child in class, they're going to go to the actual classroom. If they're going to observe people in their workplace, they go to the actual workplace, et cetera, et cetera. So structured versus unstructured has to do with how the clinician is doing the observation. Controlled versus naturalistic has to do with the setting in which that observation is going to take place. And then finally, before I end this video and go to our last one for today's class, observation formats, slide number 25. So again, just to summarize, structured, unstructured. Structured observations tend to be quantitative, whereas unstructured observations tend to be what we call qualitative. Quantitative means there's going to be a numeric scoring system. In other words, something's going to be added up at the end. It's going to produce a summary score, and that score is going to have some meaning in terms of the observation. Unstructured is qualitative, which means there's no scoring system. There's no numbers involved. There's a narrative. The clinician takes notes in written narrative form, like the child and the parent are in conflict, not number 5, okay? And in this case then, the clinician is left to figure out the meaning of these narrative notes. Whereas in the structured case, as in the video I asked you to look at, there's a checklist, there's behaviors, check marks, and the clinician adds it up at the end and makes a determination about what the score means within a range of possible scores, okay? So, for example, let's say the clinician is looking for parent-child conflict. If she has a structured observation form ready to go, she has specific behaviors that indicate conflict, and the higher the score, the more conflict there is. If she's doing an unstructured observation and taking narrative notes, she has to look back later and figure out how to code that in some way that makes tangible sense and allows her to arrive at a conclusion. Now, observations can be subjective, especially unstructured, because they're going to be influenced by the orientation and theoretical training of the clinician. I mean, even with a structured observation format, the clinician might be biased to notice certain behaviors more than others and give them more check marks. So we have to be careful in observations because clinicians come to the observation with certain expectations and certain theoretical biases. That's why blind observation is a better route. It doesn't always happen, but it's a better way to do it to eliminate clinician bias. What that means is the person doing the observation has no idea why the observation is being done. They're told if it's structured, here's the form, look for these behaviors. If it's unstructured, look for these behaviors and make your notes. But it's better to have blind observers who are not intimately involved in the treatment of the individuals being observed. Cultural differences. I talked about this in a previous video with interviews. The same holds for clinical observation. Cultural differences between client and observers can cause misinterpretations of client behavior. Nonverbal behaviors, right? We talked about this in a prior video. Nonverbal behaviors can be misinterpreted if there are cultural differences between the clinician doing the observation and the person being observed. It's going to mean something different to each of those persons, and the clinician might misinterpret it as evidence of something that it isn't. Finally, the presence of an observer influences client behavior in a multitude of possible ways. Reactivity can happen, or inhibition, or impression management. Reactivity means you alter your behavior intentionally because you know someone is watching, right? And this is like, you know, it makes sense. We're on our best behavior when we know we're being observed, right? If someone comes into your workplace to do an assessment of how much you're working or how hard you're working, and you know they're going to be there, of course you're going to be on your best behavior, right? Same with classrooms and students. So we have to worry about people intentionally changing their behavior if they know there's a clinician watching them. I worked on a case years ago where I had to observe a father and his child. The father was accused of sexual misconduct with his children, actually. He had two. He was coming into the office to be observed by me. He knew why I was observing him. So of course he might alter his behavior knowing that I'm observing him and his child for accusations about sexual abuse. Inhibition is another problem. Sometimes when people are being observed, they become more inhibited. They know they're being watched and they feel uncomfortable and self-conscious. So you might not get an accurate indicator of what their behavior is actually like if they're too inhibited, right? Finally, impression management. We talked about this with regard to self-report tests, the self-serving bias, but also we talked about impression management, which is the social desirability bias. If people know they're being watched, they will alter their behavior potentially to show their best self, to give an image to the observer that they're better people or different than they really are, right? So the best way to do these observations is to have them done without individuals being observed knowing. There are different ways to do that. It's not always easy because sometimes there are consent issues where the person being observed has to consent to being observed. So we have to be careful with privacy violations and things like that. But sometimes what will happen is, in order to deal with these reactivity, inhibition, and impression management issues, sometimes what will happen is the observer will come in before doing the observation for a week or so that people start to do what's called habituate and no longer notice their presence. So in a classroom, for example, the observer might come to class for 7 days and just be part of the class and not actually start observing until day 8. People habituate to their presence, meaning people stop noticing that they're there. And then they might get a more authentic indication of how the individuals being observed actually behave when they don't think they're being watched. Okay? All right. I am going to stop there. I will meet you on our last video of the class. See you soon.